I love this picture. This should be our mindset when we think of the future of our infants in our NICUs. Outcomes: how we would want infants in our NICUs to eat later in life, being eager feeders. Our disclosures are as follows. Kristina and Matt Russo have no disclosures. Elizabeth Jeanson has no relevant financial disclosures, and her non-financial disclosure is that she's a Dandelion clinical consultant. And my disclosures are that I'm a co-owner of Engage, Grow, Thrive and co-developer of the Small Baby Care Specialist program. Our objectives are as follows. And our time together today I want to start with, what do we already know? What do we know in the evidence that should prepare us on what we teach during that feeding experience in the NICU? The next is, what are we actually expecting of these little babies whose brains are still growing? Do we always really think about that when we're starting feeds and moving through the trajectory of feeding success? Also, how important maturation is, and how do we teach that to families? Talk a little bit about our feeding cultures in the NICU and of the language we use, and then summarize and have a question and answer period. So let's start at the end, as it really sets the stage to how we should practice. So what do we already know about the NICU feeding experience? We know that it can be one of the major reasons for a delay in hospital discharge. We also know that it causes an increased cost for an otherwise stable baby. These babies are in room air. They're just growing and staying just for feeding. We also know that feeding is the most complex motor behavior that the infant accomplishes and has to complete in the NICU. We also know, based on literature, that feeding difficulties extend not only to the ELBW and VLBW infant, but also into the LPI. So if there are feeding issues in the late preterm, we can imagine all those feeding issues in the tiny preterm baby. We also know that it can be one of the longest periods of time for the NICU stay, and a time where parents are the most tired and ready to go home. Do we really know what families experience once they leave our NICUs? Do we know what they struggle with, so that we can learn how to better educate, how we can come alongside and support them during this time? Parent stress is intensified as they worry about missing feedings, coordinating feedings with meds, and balancing life in general. They feel very ill prepared for the time and energy for feeding activities. Families have shared, our lives basically revolve around just feeding him. It's definitely taken stress to a new level. How much more should I give him? How do I know when he's not hungry anymore? Or if he's not hungry, did he get enough milk in his feeding? We want families to be excited about going home and not stressed. We want them to finally enjoy their baby. So finally, we know that feeding skills is a learned behavior. It's our responsibility as a team to make sure infants develop effective and successful feeding skills. As care providers, we can influence the pathway of their development through our practices by either supporting or impeding the ability of the infant to self-regulate and learn. In part one, Mindy and the team talked about the importance of neuroprotection and neuropromotion during the early weeks of hospitalization. Providing those opportunities for appropriate neurodevelopment and sensory development sets the foundation for future activities such as feeding. They spoke about the importance of skin-to-skin and non-nutritive breastfeeding and early taste trials. But most important, how all of these experiences establish the relationship between the infant and parent, that reciprocal trusting relationship.
We were really lucky in the NICU to have so many team members that we met before our babies were even born. So when I was in the hospital on bed rest, members of the lactation team from the NICU came down and met with me on numerous occasions. They met with my parents, they met with Matt, they met with a bunch of family members to give us a lot of realistic expectations about feeding in general. And they even went a step further and talked about feeding preemies versus feeding a baby who was born full term. So it was a really, really helpful experience, not only to have education ahead of the time that the girls were born, but also to just have a ton of familiar faces when we walked up to that NICU on the day that the girls were born, which was pretty overwhelming if you didn't know anybody.
I couldn't agree with that more. The familiar faces was so important. And those people are people who we have stayed in contact with ever since. And it wouldn't have made the feeding experience the same if we hadn't have had those relationships beforehand. One other thing that was really important to us and to me as the dad was the skin to skin time. And I didn't really know how important that would be to me as the father until the first time that I did it. And having that tiny, tiny baby on my chest and being able to feel her skin was just one of the most amazing experiences I've ever had. And I would tell every dad to make sure that you spend as much time having skin to skin with your child as you possibly can.
It was also really helpful from my perspective because when you see your babies in the NICU, you have this sense of helplessness. Normally, when your baby is born full term, you're able to be in the hospital for a short time and then bring them right home and move about your daily routine. But for us, because there was a lot of things that we couldn't do for the girls right away, having skin to skin was such an incredible bonding opportunity. It helped us to feel motivated to incorporate pumping and nursing and to create a plan that worked for feeding, that worked really well for our family. Also having tools and supplies for twins specifically in our case was so helpful because we were actually able to do skin to skin with both of the girls at the same time, or we could do skin to skin one at a time. And it just made it a special, special opportunity for us as not only NICU parents, but parents of twins.
If you haven't noticed yet, I like to ask a lot of questions. It's important for us to keep a spirit of inquiry because that's how we stretch and that's how we learn. Do we truly understand what we're expecting from the infants in the NICU during the feeding experience after they have been born 2 to 3 months early and many of them having severe complications? In the past, I approached feeding from my practical experiences rather than understanding the physiology and the skills needed to eat and the competencies needed to respond. Focusing on preparing families can improve the trajectory of feedings. It helps them understand that eating doesn't come naturally to their infant. It'll be both challenging and a skill that occurs over time, sometimes a very long time. As bedside providers, our role is to be effective at guiding parents to protect their infants' feeding experiences and also understand their infant's form of communication and our role as partners in the experience. There are many feeding skills and competencies we could review in detail, but I'm going to just focus on a few. The first is feeding readiness and disengagement cues. The competency needed is the ability to observe and have accurate interpretation of those behaviors, appropriate responses, and the ability to respect the infant's limits. An important feeding skill is co-regulating sufficient breaths and understanding why preterm infants are at risk for insufficient breathing. Safe oral feeding requires proper oxygenation. The competency should be at our ability to shift the infant from sucking to breathing and then back to sucking, along with the need for and timing of providing breathing co-regulation. Respiratory rates typically range between 40 to 60 breaths per minute, with an average of 1 to 1.5 seconds per breath. A swallow may last between 0.35 seconds and 0.7 seconds. So some infants may not have time between swallows to comfortably breathe, threatening the balance of oxygenation and ventilation. Episodes of swallowing apnea, commonly seen in preterm infants in the NICU, may facilitate oral feeding at the expense of breathing. While studies show that suck-swallow rhythms can become stabilized prior to 36 weeks, research is showing that improvement in coordination of respirations and swallows begins later. Regulating milk flow is also an important skill. The competency is having the ability to evaluate the match of the infant's capacity to manage milk flow with their organization. We need to understand the potential impact of milk flow on feeding behavior, their strength of sucking, the length of suck burst, the contact of the nipple on the tongue, milk spills, threats of aspiration, all of those things, and then choosing an appropriate feeding system. Now that we've assessed the feeding skills needed for successful feeding, our question needs to be, are they maturationally ready to start feeding? This is a really important question because if we know that the premature infant has to overcome immature sucking patterns, and suck-swallow breathing coordination, especially for those infants that might have chronic lung disease with decreased endurance. They also have to overcome immature state control and a developing nervous system that is still premature. And if they need all that to develop successful oral feeding, how can we acknowledge the complexity of what they are trying to do and push them beyond what they're able to do? We know that maturation is a sign of competence. A study in 2020 by Bobby Pineda looked at identifying the difference in feeding skill performance of preterm infants and term infants. And they used a standardized feeding assessment tool. There were 92 infants, 44 were preterm infants that were born less than 32 weeks, and then 48 full-term infants. The results showed that preterm infants at term equivalent age had lower neonatal eating outcome assessment scores, 67.8 plus or minus 13.6 compared to 82.2 plus or minus 8.1. They were more likely to have, the preterm infants were more likely to have poor arousal, poor tongue positioning, suck, swallow, breathe discoordination, inadequate sucking bursts, tonal abnormalities, discoordination of jaw and tongue during awake states, and difficulty completing the feeding. So their conclusion was that there is a broad range of feeding-related difficulties that remain evident in preterm infants at term equivalent age. In my preparation for this lecture, I came across a article that is a little bit on the old side, but it really revealed this great chart, I think, for all of us as interdisciplinary teams to be aware of, and also for parent education. And we've all experienced either a provider or a parent that, pushes past what they're able to do. And having the knowledge of maturation, I think, can help us to educate and encourage them to understand their baby is right where they need to be. And this chart here, you can see, compares 32-week infants across the board each week to 36-week infants, looking at suction pressure, millimeters per mercury, sucking frequency per minute, sucking duration per second, and sucking efficiency. And you can just see, even from 32 to 33 weeks, how some of these values double. So we need to see that and share with families that over time, we see that the more mature you allow an infant to be, the more proficient and competent they become, moving to full oral feeding sooner. So when we're in the beginning stages of feeding readiness, no matter what scoring tool we use, do we wait maybe one more day to see if they're consistently ready, or do we rush into starting feedings? Because either the parent is requesting it, or maybe the provider is saying we need to move along. Will one more day show us more about the baby's needs and that consistency of their readiness? There isn't one of us who can take care of an infant 24/7. That's why teamwork is so important. Our goal is to be a group of credible and competent individuals with the same goal and purpose of providing excellent and consistent care over time. Care that's received by the infant and family depends both on our synergy as professionals, but also our individual competence and caring behaviors within each field of our expertise. Parents see competence and caring behaviors when the team communicates well together and experiences behaviors that encourage parent involvement in care as equal partners as we share knowledge and goals with them. Each of us brings our own unique perspective and expertise, and that expertise needs to be experienced by the family. The challenge, though, is how to balance that expertise, function in our roles while providing collaborative care. Many of our roles overlap. We want to make sure our roles complement each other and not compete or duplicate services. Families really need to feel one plan and one voice and not have to filter impressions or stepping on toes. Continuity is just as important as teamwork. It includes good care and coordination between providers to maintain consistency. For families, it's the experience of care is connected and coherent over a period of time. It's about us as individuals, it's about our unit processes, our relationships and partnerships that create the continuity for families. From a parent's perspective, lack of continuity of care are variations and contradictions in their infant's care that can signal potential danger to them. It looks like this. Parents notice something was changed or missing, and either, number one, an explanation wasn't provided, two, the explanation didn't reassure them, or the explanation was in direct contradiction to their knowledge or past experiences or what they heard or saw. It looks like this. A family said, there were too many nurses with too many different ways to try to get you to do it. You'd try really hard with the way that one nurse would do it, and then you'd come back for your next feeding. And it would be a different shift, and there'd be a different nurse, and they'd say, oh, no, 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 you're holding her wrong, or you shouldn't do it that way. Do it this way. Every day with 4 feeds, you can get, say, 2 or 3 different nurses. It just gets frustrating.
Every NICU has a team of people working on feeding. According to Merriam-Webster's dictionary, a team is a number of people associated together in work or activity, also known as a crew or a gang. I love thinking of the NICU feeding crew, like a hip-hop crew. All members work together, yet each member has their own specialized dance move to contribute to the dance's success. In some NICUs, that crew is just 2 people, the parent and the nurse. In other NICUs, there are several crew members. These might include the parent, who I call the feeding implementer. They feed the baby. The nurse, who I call the feeding advisor. They advise the parent what to do during the feeding. A speech or occupational therapist, who I call the feeding expert. They assess infant performance and create an individualized feeding plan. They're also known as the primary feeding therapist. The team might also include a developmental or motor therapist, who I call the feeding supporter. These observe feedings and the feeding plan implementation casually or coincidentally during other therapy activities. They are also known as the non-primary feeding therapist. And the MD-NNP, who I call the feeding administrators. They write the feeding plan orders. Whether your NICU has a large or small crew providing feeding support, several aspects of team effectiveness have to be present for a smooth and successful feeding program. First of all, crew members must follow the coach-directed choreography, i.e., follow the protocol. Everyone on the crew should be knowledgeable about the feeding protocol, respectful of each dancer's contribution, remember the tips and tricks commonly used during a feeding, and what is typical and atypical performance. 2, members of the crew must know their role. Parents are primary caregivers. Their role is to provide feedings and feedback about their infant's performance. They must be knowledgeable of the feeding program, the maturation of feeding ability over time, the importance of early exposure to tastes and feels, the value of parent presence for trust building and positive oral experiences, as well as in-the-moment tips and tricks for promoting feeding. Lastly, the performance must be reviewed. Roll that footage, Dave. Feedings and feeding implementation must be observed and coached until consistent performance is achieved. Think how many times a dance crew runs a routine, over and over with corrections, a process called cleaning, until it's innate in all the dancers. A successful feeding crew is able to repeat the feeding interventions over and over with corrections by the primary feeding therapist until the parent's able to feed their infant independently, safely, and successfully. A cleaned routine. That is not to say that practice is what makes feeding successful. We are talking about the practice of parents implementing the feeding plan, not the baby practicing suck, swallow, breathe coordination. The baby, as Liz so eloquently described, must mature over time. In our unit, we have a feeding expert, the speech therapist. She assesses infants' maturation and skill, as well as parent comfort and knowledge with the information. She uses that information to create an individualized feeding plan based in our overall feeding protocol. This information is communicated to the parent and the nurse and the medical team. Every day, the feeding expert assesses infant performance and adherence to the plan, making corrections as needed. In some units, the nurse fills the role of feeding expert, feeding advisor, and feeding supporter. Given the longevity of nurses in NICU, it is completely possible and practical for a nurse to serve in all these roles. However, when available, the training and expertise of a speech or occupational therapist in the role of feeding expert can be highly productive. Both NAN and NANT recognize the role of the therapist in the NICU and that includes feeding. In our 62-bed unit, there is no way for our feeding experts to observe every feeding opportunity. They can't tell by chart review what happened prior to or after the feeding. That role often falls to the non-primary feeding therapist, who in our unit happens to be PT or OT. Please note that in many units across the country, OT is the primary feeding therapist and does the assessment and designs the individualized feeding program. However, in our unit, it's a speech therapist. Although the non-primary therapist may feed babies, their specialty dance moves include education and observation, reporting and supporting. The value of the non-primary feeding therapist cannot be underestimated. In the role as educator and observer, the non-primary feeding therapist serves as a reminder of both the individualized feeding plan and the overall feeding protocol. When I'm in that role, I review the cues and interventions as the baby moves through a feeding, offering reminders as needed. After feeding, I can review how the protocol moves to the next step, or refer back to the primary feeding therapist for more input. That leads me to another role of the non-primary feeding therapist, that of supporter. Most parents have never fed a preterm infant before, and some have never fed a baby at all. They don't always know what to do or remember what they're supposed to do. Whenever anyone is learning a new skill, reminders are helpful. When learning that new skill under a stressful situation, clues and reminders are necessary. Receiving positive affirmation builds confidence and consistency. The non-primary feeding therapist, by nature of their touch points during the baby's day, usually before and sometimes right after feeding, has the unique opportunity to offer parent support. The non-primary feeding therapist can offer specific input in the moment and specific affirmations in the moment versus just an overall, "Good job on that feeding, Mom," that she might receive later. The fourth role of the non-primary feeding therapist is reporter. In our unit, the primary feeding therapist reviews the feeding flow sheet each day. From that, she can see the volume, position, time, nipple, and spells the baby experienced. But she can't see the parent or nurse performance, i.e. the pacing, the timing of the pacing, the fatigue of the baby, the burping frequency or duration. Direct visual observation and reporting in real time is the gift of the non-primary feeding therapist. I can report immediately back to the primary feeding therapist after casually observing a feeding. The non-primary feeding therapist can fill in situational information, creating a clearer picture of what's happening. Maybe a baby got an IV placed before breastfeeding and was extra sleepy. These observations and reporting back to the primary feeding therapist allow the plan to be tweaked or not tweaked based on the actual situation versus chart review or word of mouth. When navigating from oral exposure through discharge oral feeding, having clear, accurate information is an advantage. Not only does a non-primary feeding therapist play a role on the feeding crew, but they also have expertise that can promote feeding in a more foundational way. Neonatal physical and occupational therapists have expertise in creating motor foundation for better performance during feeding. Through the use of therapy techniques, posture and muscle tone can be manipulated to create the optimal alignment and activation for a feeding. For example, an infant with a long history of mechanical ventilation may have a postural bias towards neck extension. This bias will be present during feeding, making latching more difficult and swallowing more dangerous. PT and OT prior to the feeding can reduce this tendency, while ongoing PT and OT can change the postural bias to a neutral head and neck alignment. The old adage, "if you can't breathe, you can't eat," is true. If the breathing problem is muscular or postural, OT and PT can be a great asset as they know techniques to improve both of these aspects of respiration. Given the long hospitalization, need for ventilatory support, and the level of illness most infants with feeding challenges endure, there are few infants who would not benefit from this type of occupational or physical therapy intervention.
It was really important for us to feel and be valued members of the team at the NICU. Matt and I spent every single day at that NICU, made it our 8 to 5, 8 to 6 all day job and responsibility. And we really learned so much from being a part and being a valued member of the team. I think we were really lucky that we were able to spend as much time as we could in the NICU. I was able to take all of my maternity leave before the girls were born because I was on bed rest for so long. And my job was really unique in that I had a more generous maternity and leave time. And so because of that, I was able to spend a lot of my time in the NICU. We had no other kids at home to help manage or be caring for. And I think now that we're in the middle of a pandemic, it's so important to identify unique ways for parents to connect and be a part of the team, especially because there's probably not a lot of opportunity for both sets of parents or multiple family members to be in the NICU like they were when we were there with our girls.
I think that another really important aspect of being a part of the team was participating in rounds. We made our best effort to be at rounds every single morning. And that was non-pandemic times, and it was still very difficult for us to do that. But enabling parents to participate in rounds is something that it was so valuable for us. And I know that others would find the same value if they either know that that was an opportunity that they have to participate in, or in unique times like these, give them a different way to participate in rounds. Perhaps there can be separate Zoom meetings that can be set up for parents that aren't able to be there with their families in the hospital every day.
And I think the key to being the valued member of the team is just communication. During rounds, we loved being there because we felt like it was a great opportunity for check-in with our team of providers to set new goals, to set realistic expectations, to help us better understand what challenges were present at the time, what strengths, what weaknesses our girls had. And our NICU was incredible about always communicating with us and making us feel like we could communicate back with them. So when it comes to feeding and thinking about how we could take that a step further, just continuing to ensure that there's communication with primary nurses, with the OT that's working with the babies that are in the NICU, and potentially having a small mini round with the provider who is really helping to move the feeding process along so that the parent feels engaged. And then potentially having other people or other members of the family having that same opportunity so that there's equally as much support in the NICU experience, but also as the family's planning to transition home.
We just heard Kristina and Matt talk about how important communication was and being an integral part of the team and that partnership during rounds. Now I want to talk about what about communication with the infant? We know that our goal is to go home with an infant that has the skills to eat and parents having the ability to understand their infant's communication. That means that really the infant is the team leader, so to speak. They're kind of queen and king of the castle here. Do we see the infant as actually the active part of the feeding process, directed by their needs and based on their cues? How do we prepare families? Do we have tools at the bedside like we shared just a few minutes ago? Do we have education on maturation and the importance of that? Do we have explanations of what other families have shared? We have, spoken to families saying this feeding period is a marathon. We recently had a family where we shared that, and the dad said, but you're not giving us any water breaks. At least in a marathon, you have water breaks. What are those ways that we can get families through that long period of time? What about our language? What kind of language do we use? Do we say things? Do we really focus on volume or quality? What do we post? If we say it's really about the quality of the feeding, but then we post things like, I finally took a full bottle, what is that mixed message? Do we stay focused on maturational skills? What are some other language variations we use? Do we say things when we're when a family is trying to feed their infant, do we maybe take the infant away and say, here, let me try? What do those words mean to families? How do they hear them? What is our feeding focus on during daily rounds? I know most of our units would say we're focusing on growth. Are they following the growth curve? How many grams did they gain? This one mom said the grams, I mean, if all it comes down to is this, they will be discharged when they're putting on weight, then obviously to me, putting on weight is more important than breastfeeding. If they said your baby will be discharged when she's breastfeeding, then that's completely different. But if it just comes down to the grams, then who cares how they get it? What does our environment look like? Is it set up for success? Is it a dim environment? Do we minimize conversations? What are the techniques do we use? Do we teach parents pacing? Do we teach parents the importance of positioning? We have to realize that we are just guides and supporters. Feedings really are something between the infant and the parents, and something that can be positive when it works. So what other things are going on in the family? Are they trying to balance life at home and life in the NICU? Parents are so divided when they end up here in the NICU. And if they have other children at home and they can only come in for one feeding and the baby isn't queuing, how do we support that mom for those moments? Do we say, your baby isn't queuing right now, however, you came all this way, let's do skin to skin, you can hold during the tube feeding? What are those ways that we can come alongside and encourage and support families?
I think that the room and the space that we had in the NICU was so important for my own personal feeding journey with our girls. And it really helped me to build a better partnership with my team, which was our NICU primaries, our OT, and all of the feeding specialists. It was so important because I really wanted to feel like there was a space of my own and something that felt more like home than being at the hospital with my girls every day. And so our NICU had a pumping room that was separate from our girls' room. And although that was so helpful, it just was still very impersonal and reminded me every day that I was in a hospital, that my babies weren't home, that they were having some struggles. And so having the opportunity to have a space and a room that felt more private, that allowed us to kind of spread out and feel like we were at home, where I could pump beside the beds and the isolettes for the girls, that was really, really helpful for me and really motivating for me to continue feeding the girls as much as I possibly could. I think that there's also some other great opportunities for unique ways where parents can learn how to feed their kids in the NICU. And a lot of the times that we were there, we had the OT teaching us how to feed. We had the primary nurses training us how to feed. And it would be interesting to verify or validate that learning experience, to have the parents teach some of the non-primary nurses who may be covering on days when the primary nurses or the OT aren't available to do the feeds. I think that it extends the parent learning opportunities in a different way. And it's beneficial not only for the time during the NICU, but after the NICU, because ideally, not just the parents are the ones that will successfully and safely be able to feed the babies when they go home.
From my perspective, the feeding experience was, I saw it as a bit of a challenge. I work in professional sports, and sports make up a big portion of my life. I watch them, I participate in fantasy football, and I saw this opportunity to learn how to feed our children as a challenge and as something that I wanted to perfect. And by looking at it like that, I had to study, I had to watch the experts, I had to manipulate my arms and my hands to get in the exact right area to be able to have them take as much of that bottle as possible.
Yeah, and I think that the NICU can be a pretty intimidating place. It's so quiet and a little bit eerie in some ways. And something that made us feel really safe, and that could help some families feel safe during their time in the NICU, is to consider having a more quiet opportunity with the monitors. So the monitors, as everyone knows, can be going off at any time. They can be alarming, and they can cause, parents to worry, oh my gosh, if the monitor went off when I'm feeding, what did I do? What's going on? Did I do something to hurt my baby? And so potentially having the opportunity to turn the monitors down during a feed, and just have the primary nurse physically watching the feed and providing feedback as needed if there's an issue for the baby during the feed, just so it provides a more similar experience to being at home and giving that parent or the feeder that nurturing opportunity to bond with the baby, and hopefully offering that baby more ounces during that feed. And then even some ways to help engage parents who can't be there all day is to potentially have the primary nurses filming one of the feeders that is there in the NICU. So it could be a chance for the parent to be feeding, and then the video is recorded, and then feedback's given afterwards, so that there isn't as much interruption or stop and go in the event that the baby's in a good rhythm and then gets distracted by hearing a lot of noise going on. So I think there's a lot of great opportunities to engage families and help them feel nurtured and supported, but also to help with the common goal of feeding the baby safely and getting them back to being at home.
I really like the idea of videotaping feeds. If I can use a sports reference again, but that's what a lot of professional athletes will do, is they will film themselves practicing. And if the parents can film themselves feeding and watch it back and take constructive criticism or constructive feedback from the feeding team, that would be a really cool opportunity and a great way to get better, as in any business or any sports team or any other aspect of life.
And even to help other feeders at home who can't be in the NICU when you're done with that NICU experience.
If a preemie could talk, what would they say to their mother or father during those first attempts at feeding? Maybe something like, "Mom, you've got this." Or, "Dad, you make me feel so safe. I like feeding with you." Or maybe even, "Thank you for letting me be done. I'm too tired to keep eating." Feeding an infant is an interaction of communication. It focuses on feeding quality and parents' relationship with their infant, and helping parents conceptualize feeding as a conversation with their infant. Our role is critical in providing consistent guided participation learning opportunities for parents, so that parents gain the feeding competence to take their tiny family member home. Anticipatory guidance is a way to begin problem solving as parents learn their infant's perspective and how to modify their interventions. Feeding skills are complex, and as they're learning, we help parents explore what happened, what was learned, what to do next, and what to do differently. Parents share that when they listen to what their infant is saying, they don't feel that they're feeding their infant on the edge of their chair, just waiting for them to have a choking spell or a DSAT or turn dusky. Parents need to proactively structure feedings to prevent stress and rather anticipate what support their infant may need. Here's some great examples of anticipatory guidance if a care provider was demonstrating a feeding to a family. Saying something like, "Did you see how Lily pushed the nipple out with her tongue? She might be telling us she needs more time for breathing." Or something like this, "When milk is spilling out of her mouth, Lily might be trying to tell me her mouth is too full. I'll give her a break from sucking so she can clear her mouth. I think she liked that. What do you think, Mom? What do you think, Dad?"
Let's take a closer look at the way we convey information to the parent. In any stressful situation, information must be presented several times for all the details to be captured. Information about factors that impact feeding must begin when those factors are actively affecting the baby early in their stay. An infant requiring positive pressure ventilation for several weeks might have trouble with swallowing and reflux. The infant who requires an OG-VEN, an OJ for feeds, and an ET tube isn't able to move their tongue in the typical non-nutritive sucking pattern. After weeks of practicing a modified pattern, they may have trouble with demonstrating a nutritive sucking pattern. Parents need gentle presentation of these early factors that affect feeding. This helps them to set realistic expectations. Isn't it better to say, wow, Johnny defied the odds and his medical history to become a great breastfeeder? I'm not saying that we should set parents up with an expectation to fail because of the medical care required to keep their baby alive. However, without this knowledge, we do set them up for unrealistic expectations of success when their baby reaches room air or term gestation. Focus. Parents and the medical team members need gentle reminders that our focus is positive feeding experience and that patience versus persistence is the key. A great non-medical example of this learning is learning to play an instrument. Take the piano, for instance. Wouldn't it be great if your 6-year-old could just sit down and play the theme to Harry Potter? Even if they can read music, they can't play it because their anatomy doesn't allow the finger stretch between the keys to reach all the notes. Their anatomy must catch up. For a while, the adult has to help the child complete the task, but when growth is complete, the child can play the full song independently. This is true for feeding as well. As caregivers, it's important to remember and to convey to parents that time leads to maturation, not practice. Clarity. If you're familiar with Brené Brown at all, you know her famous quote, "Clear is kind." Clarity holds true for feeding feedback as well. Saying that a baby did well bottling overnight when you're actually thinking, I had to pace him every 2 sucks and his heart rate spaced out 3 times, but he never spelled, isn't accurate. Another common yet unrecognized lack of clarity is when the nurse says she got the baby to take full volume all night long, but fails to mention there were 3 position changes, there was frequent burping, she rotated the bottle, she rubbed his back for waking, and stuff dribbled out the side of his cheek. Professional caregivers can fall into the trap of summarizing information. Failing to present a clear picture of what was needed to get the results that we got can crush parent confidence. Accurate information in parent-friendly terms is a necessity to support realistic expectations and thorough translation of information from professional to parent. Affirmations. It is human nature to respond to praise with repeated action. Even praise laced with constructive criticism will produce improvement in activity for most individuals. Telling parents what they're doing right, even the smallest action, builds confidence and consistency. Try pointing out each time that a parent does the correct action, such as, great job reading those cues, or your pacing was just right for him. Your instincts are correct. He's done eating. Using affirmation can build parent confidence and improve the parent-infant communication in a way to promote feeding. Preparing a parent with information, clarity, focus, and affirmation aids transition to discharge. But what about after discharge? The team changes. What once involved 3 or more people now might only involve 2, the primary care physician and the parent. New members on the team unfamiliar to the parent may include gastroenterology, feeding clinic, outpatient feeding evaluations, and breastfeeding support group. Part of the discharge plan should include how to advance the duration and frequency of breast or bottle feeding, where to get specialty nipples or bottles used in the NICU, and how to advance to the family preferred bottle if that's not already completed. Without the NICU's strict tracking of feeds, parents need to know how to measure success. Wet diapers, sleeping, fussiness, spitting up. It is typically the PCP's responsibility to guide advancement in volume or frequency, and keeping track of infant weight gain and hydration aids in making effective recommendations. The need for brain support through nutrition and skin-to-skin contact doesn't end when the NICU stay ends. Information about supporting normal development through good nutrition, health, and interaction should be provided. In our NICU, parents receive both verbal and written information about where to buy bottles and nipples, nipple advancement, fortification of feedings, and developmental guidelines. Any NICU graduate who discharges breastfeeding can attend breastfeeding support group for free as many times as needed during the transition. Babies born less than 35 weeks are referred for early intervention. Any infant requiring a specialty bottle, thickened feeds, or a specialty formula are referred to both gastroenterology and feeding clinic. Infants who go home eking out, meaning they're just barely taking the required volume for growth, are referred for outpatient feeding evaluation. Parents who require specialty formula or thickened formula must practice making the formula several times prior to discharge, ensuring that once they get home, they really will be able to make the right combination. The journey to successful feeding doesn't end at discharge. Setting parents up with support is a vital part of the discharge process.
I remember calling the pediatrician when the girls were 8 months old and basically asking for permission and apologizing at the same time because I wanted to start formula feeding. And I think creating a journey that encourages a realistic lifestyle and one that mimics post-NICU life is really important from an early stage when parents are in the NICU with their babies learning how to feed. I think it's so important that it's enhanced how critical breast milk is for growth and development, but finding mediums to support the family as they're transitioning out of the NICU and the hospital and going back into real life. One thought that would have been really helpful for us is to create feeding plans for families to take home with them. So even if the goal for the family is to pump or to breastfeed or to nurse, then providing a few options for the family for the days when those feeds just aren't going well or they aren't looking exactly like they once did in the NICU, or life just happens and there needs to be an alternative to support the family so that they continue to feel motivated and don't burn out because they didn't expect anything that was different than their NICU experience.
The stress involved with bringing your baby or babies home is obviously very high. It was, incredibly high for us, bringing home two NICU babies. But I think that we definitely learned some really great strategies from the NICU team in terms of how to deal with that stress. But any sort of counseling in terms of just what life will be like at home, and making sure that everybody knows that it's going to be dramatically different, and you're doing a great job. Just like every other parent who doesn't have a stay in the NICU figures it out. Ultimately, when the parents get home, they will be able to figure it out as well and make the journey their own. And so, everything from learning that at the end of a feed, you actually need to wash your own bottles, and you don't just get to hand them over to the nurses. Those types of things were a bit of a shock for maybe the first day or so, but slowly you get used to it, even though it is such a big shift.
Yeah, I think that in the NICU we were so fortunate because we did have our own private space and we spent all of our day there, but a lot of our day was spent doing skin to skin, working on feeds, participating in grand rounds. So in a way, we were able to really isolate ourselves from that real day-to-day life experience. And I think that the more realistic expectations that can be provided from the beginning for the family about what the daily schedule will look like at home will just help the family to feel as empowered as possible. And I think variety is something that's really important to emphasize. Our daughters were really, really difficult to feed. And once I finally figured out how to feed them and we were in a good rhythm, they weren't having a lot of spells, I remember feeling so stressed every time that a new feeder had to come in. Even when it was nurses in the NICU who weren't the girls' primary nurses, I would feel sometimes that they would have more spells when it wasn't one of us who had become the expert or the main primary feeders. And that would cause a lot of stress and anxiety in our day-to-day. And I think this was a huge challenge for me as a mom because I really loved that I could care for my girls. I finally had this opportunity where I could feed them. There was something that I could do that helped them. But in the end, it left me feeling really isolated, and it was really difficult to seek support from family at home when they weren't trained to be as strong of a feeder as I had been. And it made sleeping and resting really, really tough because our girls didn't nap well and I was pumping constantly. And so when they were sleeping, I was pumping, and it just led to this cycle of not a lot of rest and not a lot of extra support that would have been really, really helpful. And I just remember being so, so tired during the period when our girls finally did come home. And so I think it would really help families, and especially moms, to really reduce burnout if there's an emphasis on planning for real life expectations and emphasizing self-care and seeking out additional support or ways for other family members to become those feeding experts alongside the primary caregivers at home.
Finally, just any resources that are available to parents to be able to take home would be extremely important. As Kristina's talking, I'm thinking of some resources on how to deal with and manage stress of coming home from the NICU. Is clearly, there was quite a bit of it that. Some of it was well placed, and others it was just the lack of understanding of what life would be like, when we finally got home. But any other videos that parents can watch, or community groups like past NICU parents that can talk to those that are about to leave the NICU about their experience. I think would be extremely helpful, if nothing else, just to tell them that they've got it. At the end of the day, you're going to do a great job, and it's okay if your child doesn't want breast milk and they want formula, things of that nature. Everything is going to be okay, and you're doing a great job, and you're doing the best thing you can for your child. And so, yeah.
Yeah, and I think just reminding parents as well that even though you leave the NICU with your babies, that family, that NICU family, is still so much a part of your life, and the NICU wants to hear from you. They want to hear about how well things are going, or if there's any struggles that they can help you identify or fine tune and make your life easier. And they just want to continue to be a part of that journey that you all went through together as a team. And that was something that we were really, really thankful for when we got home, is that we did stay in touch with a lot of our primary nurses, and anytime we were near the hospital, we'd be sure to go and stop by, even as much as to say hi to the security people at the front desk who knew us because we were there so frequently. So I think just reminding families when they are leaving that the NICU is your extended family, and they're cheering for you and supporting you not only during your journey, but even after you leave.
When I walk away from a learning experience, I want to bring something to my next experience in the NICU, either with a baby or family. We learned we can impact that later experience before the infant is even born. Early parent education regarding the importance of human milk, neuroprotection from day one, can help build a healthy neurosensory system, laying the foundation for later feeding. The infant's inability to feed is related to the caregiver's ability to recognize and respond to their needs. How we respond directly influences and impacts their feeding experience. It's about supporting the infant's pace of maturation. As Elizabeth shared, it's about patience and not practice. Maturation equals competence. Finally, there's no better way for teams to learn what it's like on the other side of the incubator than by listening to NICU parents. We focus so much on getting babies home that we don't realize what the transition to home is really like. Thank you, Kristina and Matt, for sharing your insights on how we can better support families with your ideas during the feeding experience and preparation for going home. Thank you for letting us spend this past hour with you. We would love to open it up for questions.
that parent perspective, thank you, thank you, thank you. It is so important. And I love the phrase you said at the end, is to remind parents, and we need, we teach them and we tell them what they should be doing, but to say, you got this. And I just love that. So thank you, Matt and Kristina, for that. So just a couple questions that we wanted to ask that from our audience is one, following up from the research highlighting sucking progression between 32 and 36 weeks, Liz, do you know if there's been any more research on this topic, and have there been any changes?
In doing the research, I did find several articles that did talk about the suck-swallow coordination can come definitely before 36 weeks, but that respiratory part and that maturation in that coordination, because of how long a breath takes, how long a swallow takes, that is not as mature until after 36 weeks. And I think that is probably
Liz froze again. We'll see if she can get, oh, there you go, Liz. We got you back.
Okay. Yeah, there were a couple of articles that did talk about that breathing aspect comes after 36 weeks.
Great, thank you. How about, can you discuss feeding at all with infants with this topic with congenital heart disease? Do you have any more advice about that?
I will be honest, we actually send most of our congenital heart to our level 4. Elizabeth, do you have?
You're muted, Elizabeth.
I have to agree with you, Liz. We send our kids with complex congenital heart defects away.
We do have a webinar. And I know,
yeah.
Oh, go ahead. I was going to say there are a lot of experts in this, and we do have a webinar that we did last year with congenital heart disease too. So you can refer to our webinar for that one. I do have a question though about a team approach, which this is a great opportunity. With all the different members of a team, how in the world do you get everyone on the same page? Because as Liz suggested, there are sometimes different messages that are given to parents. And as the parents can probably say, that is very frustrating. So how do we as professionals get everyone on the same page?
I'll start with that, and then I'm going to pass it to Matt and Kristina. So, getting everybody on the same page can be difficult. It doesn't happen all at once. We did a lot of work on it. And if you think about all the members that are responsible for feeding or involved in feeding, you have the parents, you have the baby, you have lactation, you have your developmental specialist, and you have your nurses. So that's 5 people. And that's why I spoke on continuity. And I think our team in rounds, that was really pivotal in talking about that. We also, you have to respect each other's expertise and realize that our roles don't compete with each other, they complement each other. And that family and that baby needs all of us. And so we would talk in the unit in rounds, and I'll kick it over to Matt and Kristina. Did you feel like that? Did you feel like, you did mention that you were an active part of the team, and every time you said my team, meaning your team, I smiled because I'm like, it is your team. Can you guys share a little bit about what that teamwork looks like on your side, and maybe if we disagreed, how that feels?
I think it helped so much that we were there every day. So we were a part of rounds every single time that it happened. So I think any opportunity to invite the parents, whether they can be at the NICU or not, now that we have FaceTime and Zoom and all these virtual opportunities, it's almost, I hate to say the word mandatory, but it is getting a check-in on how your baby is doing that day with every single member of the team. And I think that helped us just understand where things were. And it really helped with that realistic expectation portion of it. But to take it a step further, it also allowed us to figure out, okay, well, what's our goal? What's the goal for today? And then what's the goal for the next 2 months? Encouragement piece, like, you've got this. If you're not getting it right now, if you're having a hard day, I remember, Liz, you took me down to the cafeteria. You were like, you need a break. You have to go downstairs. So it's just really feeling that camaraderie as everyone is a member of the team and checking in with one another.
That's well said. Gentle encouragement to get the parents involved in rounds, I think, would be extremely beneficial. I'm not sure how many parents actually actively participate in rounds. We absolutely loved it. And letting them know that they can and that they are encouraged to participate, I think would be terrific.
I can just say that where I work at Stanford Children's Hospital, we all learned the feeding program together, like all of the nurses, the practitioners, the physicians, the therapists, we all learned it together at the same time. So that really helped us to have consistency between the players on the field. As well as it allowed the experts, like our speech therapists and our nurse practitioners, to really give direct feedback to the nurses at the bedside about how they can improve that feeding interaction, because we all were coming from the same knowledge base. So that really helped us in our unit to build more of a consistency. So parents didn't have to worry like, nurse A is coming in and she doesn't know about my baby.
Mm-hmm. Great, thank you. Well, I think that that's about all we have time for today. So I just want to, again, thank you so much, all of you, for being here. And before we send you off, we wanted to just address, we talked a lot today about positive feeding experiences, and we encourage you to consider our learning opportunity of the infant-driven feeding program to purchase for your staff so that you can complete the unit-wide, so everyone can learn the same learning program about feeding. And IDF is an online learning program for your staff to help transform your feeding culture from volume-driven to infant-driven. And although there are many benefits to IDF, which we'd be really happy to discuss with you, one related to today's talk is that it improves the parent experience with feeding. And I just want to show you here what one mother has said about IDF. And this is Summer Mobley, and she is a former NICU mom of triplets who were born at 30 weeks. And she says that IDF was amazing for us because it helped us get to know our infants better. It taught us how to watch for their cues during and after feedings. And she also said that I truly believe if it weren't for IDF, learning IDF and having the support of the hospital, I would not have done it. And that was when she was talking about her breastfeeding experience. So feel free to reach out to us at medinfo@drbrownsmedical.com, or you can also go to our website and fill out the contact us page there as well. So thank you again. We will send you your information about your CEUs within 24 hours. Everything will be on our website. And thank you for being here, and have a great day. And we'll see you next time. Bye-bye, everybody.